All right, let's do the inflammatory bowel diseases, 2 of them, Crohn's and ulcerative, for our exam. You probably, I don't know if you read in the book, or one other thing that we could put on this one is celiac disease. But celiac disease is also autoimmune, but it's due to gluten allergy. So celiac disease, that only happens if you eat gluten. And so if you have celiac disease, they will keep you off gluten. Crohn's and ulcerative have a we don't know trigger for them. It is an autoimmune disease as well. So any inflammatory bowel disease. So I'm going to put that there just for learning. But I'm not testing you on. I'm going to put celiac disease in here with the inflammatory bowel disease. And the one that we don't have a whole lot of slides on celiac disease because it has a known trigger, and you avoid that trigger and you avoid the inflammation. The other 2, Crohn's and ulcerative, we don't really know all the triggers. They're triggered by stress, going to nursing school, getting ill, they're not just one trigger like celiac disease. So celiac disease, so I'm going to put that one up at the top because that one we kind of discount because once you figure out that you're allergic to gluten, you don't eat gluten anymore and you've cured your inflammatory bowel disease. But Crohn's disease and ulcerative colitis have much more unknown triggers or generalized unspecific triggers. And so they have constant flare-ups. We can't tell them to avoid their one trigger. So if you do see anything about celiac disease, that's only trigger is gluten. Removing gluten from your diet subsides your celiac disease. Crohn's and ulcerative colitis, again, autoimmune as well, but multiple triggers. And this constant inflammation causes changes to the vessel wall, or to the intestinal wall, and increased risk of colorectal cancers with Crohn's and ulcerative colitis, because the bowel wall is constantly getting inflamed and changed, and then it's constantly remodeling itself and an increased risk of cancers. In areas of the intestine that are damaged, we don't get our proper absorption. So if you see any of those 3 on the test, you will just see Crohn's and ulcerative colitis. Both of those are all 3 of them autoimmune inflammatory bowel disease. Inflammatory meaning that our bowels are being inflamed by our immune system. So Crohn's disease can infect any part of the intestine. Usually it is the connection between the small and large intestine. That's the most common spot for Crohn's disease, but it can affect any part of your small or large intestine. And this causes changes in your entire bowel wall. And you can see this constant inflammation leads to scarring of the intestine. And this is just basically big, huge pieces of scar tissue that don't absorb and end up causing problems. So what we see, and you will see, it's not so much persistent. Hang on, let's go back. There's a few differences between these. It is the whole bowel wall, not the whole bowel tract. There's pieces of the bowel tract that get attacked, not the entire bowel wall. So I think that's probably, this one isn't persistent. This has intermittent bloody diarrhea. Again, it depends on how much the blood vessels are interrupted, how much swelling is going on, but they will have dark red blood, not bright red blood, dark red blood. And why do you think they have dark red blood? If they're having stools, why would their bloody diarrhea not be bright red blood, but dark red blood? Well, Jen got it straight. It's older. It's been exposed to more digestive enzyme. It's happening higher. So the older and higher it up is in the GI tract, the darker it's going to be coming out the other end. So this is some dark red. It's mixed with stool. It's not just that you're having blood coming out. It's more of the tarry dark red stools. So they do have intermittent bloody diarrhea. If it is, it's dark red blood because it's higher up in the GI tract. They can have constipation because the wall is thick and damaged, and now all those cilia that move things along are all damaged and turned into scar tissue. So they're constantly having pains and cramps, constantly having a low-grade fever. And what's the low-grade fever from? Waiting for some ideas. Inflammation. Good job. So inflammation gives you a low-grade fever. Infection gives you a higher grade fever. So this is a low-grade fever because it's a constant infection process going on and inflammation to the bowel. Loss of appetite, weight loss, fatigue. Well, loss of appetite because your bowel thinks it's full and it's sending signals to not eat anymore. It's full of scar tissue, not full of food. Weight loss because we have malabsorption and they're not eating. Fatigue because the bowel system's not working appropriately. We're not getting the proper nutrients. If they go in and find this, if they can go up and look in a colonoscopy or in a CT scan, they see a thickening of the entire wall, this cobblestone appearance, that is the scarring of the area, and then areas of ulceration and abscesses. Because this is inflammation, it's kind of fragile scarred tissue, and it is full of fecal matter and digestive matter, can easily get infected. There's lots of bacteria living in our intestines. They can have the same concerns that we do have with diverticulitis. You could certainly have an abscess that ruptures through this, that becomes peritonitis. You can have bleeding because of this. It's eroding away to the blood vessels. You can have obstruction. So those are our big worsening cues with Crohn's disease. So very high risk of peritonitis and obstruction with these. And mostly the obstruction is due to the scar tissue blocking off movement. So what do you think you would do to avoid the side effects if you have Crohn's disease? What will you encourage this patient to eat and drink? Fibers and fluids work real well for the intestinal system. I don't know if it necessarily needs to be high calorie, high protein. I mean, that will help you with high calorie, high protein will help you absorb whatever you are going to. If you are going to absorb, then it will be good, high quality nutrients. But we do want to make sure that they get fiber and fluids along with their food that they're eating for nutrition, because it will keep things moving through. So yeah, you do want them, if they're having weight loss and fatigue, to be eating quality food. So when we say high calorie, a lot of patients think, ooh, I can have all the ice cream that I want. But really, if this area is not absorbing well, we do want whatever areas do get absorbed to have good quality nutrients to them. So I would say high quality diet along with fiber and fluids. But we want to keep things moving through the scarred area. You want to investigate what triggers they do have. Could the protein help with the healing process? It could, but again, we need to reduce the inflammation to allow healing to concern. This is basically being a scab that's constantly been picked at. Whatever trigger these are, and we don't know if the triggers have to do with the actual bacteria that live in the gut, that when you eat certain foods, those bacteria grow. We're not really sure what is being attacked down there. They're doing a lot of research into this Crohn's disease, this inflammatory bowel disease. But whatever it is, there is a certain area of the intestine that is just a trigger for the inflammatory system, and it constantly is getting inflamed until you can figure out what the trigger is and stop it, which we might not be able to do. And that spot's constantly being picked at and constantly healing, and just like you pick at a scab, it will turn into a scar. That is what's happening on your intestine side. But unfortunately, as the healing process is going on, and the scarring process is going on, we also have the combined issue of fecal matter moving past it. So we get that risk of infection and bleeding as well. But it is constantly like picking a scab on the inside of your intestine. So that is inflammatory bowel disease, Crohn's. Crohn's happens usually in the junction between the small intestine and the large intestine, but can happen anywhere in your bowel. Ulcerative colitis is a different kind of inflammatory bowel disease. It's still the autoimmune system attacking, but it's only attacking one layer of your colon, and this only happens in the colon. So ulcerative colitis is in the colon and the colon only. Crohn's can happen anywhere in the GI system. Colitis happens only in the colon. And it only affects the upper mucosa of the colon. And so what is happening is that the inflammation attacks the mucosa, but it does not go all the way through the bowel wall. But what it's doing is it's thinning out your colon. And causing constant sloughing of, and since the mucosal wall is broken down, you have open sores and open ulcerations. So this is basically broken down the top protective layer and is causing basically a constant ulceration of the colon. And with the colon being ulcerated, it will bleed. So this is a persistent, whereas Crohn's was more intermittently dark red blood. This is, yeah, it does kind of look like cheese and marinara sauce. Thank you. Now I won't be able to eat cheese and marinara sauce for a while. But this is persistent bloody diarrhea because the thing is ulcerated. And so it is further down in the colon, closer to the exit. It is brighter, lighter red blood, and it is persistent because you have a ulcer that's bleeding, basically. Usually no constipation, because by the time we've gotten to this size, oh my God, guys, stop. It's almost lunchtime. But persistent bloody diarrhea, usually no constipation along with this one. It's not as scarred. It is actually, the bleeding is helping carry everything out. But also a low-grade fever because it is an inflammatory condition, loss of appetite, weight loss, fatigue. What do we absorb in our colon? And if it's ulcered, we're probably not absorbing well. We absorb a lot of water, a lot of electrolytes in our colon. That's our last stop before it exits the body. So this is where we will reabsorb water if we're dehydrated. It's why if you are dehydrated, your stool, you end up getting more risk of constipation because you're constantly stealing the water from your stool to rehydrate yourself, and it ends up getting stuck in the colon. So dehydration does lead to, in normal people, dehydration does lead to constipation because the colon is where we pull the water out. And hey, we got water, we can steal that from the stool. We can steal that back in to hydrate ourselves, but then it gets stuck. On this patient, you are constantly bleeding and ulcered. You can imagine this would be a great amount of pain to have ulcers in your colon with digestive matter trying to scoot by them and get out. Causes a lot of pain, a lot of cramping, and not constipation, but you are definitely at risk of infection. Again, we've got open bleeding ulcers. I don't know if your mom ever taught you when you have something, if you've cut yourself or whatever, to let it bleed out for a little bit, let the bacteria carry the, let the blood carry the bacteria out. So this is not as easily infected because if it's constantly bleeding, the rush of the blood, would this show up in H&H values for bleeding? Oh, yes. If you have bleeding ulcers in your colon and you're having persistent bloody diarrhea, yes, you can drop your hemoglobin hematocrit because you are bleeding. And because it's an ooze bleed, it's not a big fast bleed, but it would certainly, the H&H would drop the more bleeding you have. So if it's a small little ooze that's not really causing a big change, you might not see a drop. But if there's a lot of bloody diarrhea, you're going to see a drop in your H&H. But because it is stool passing through this and there are open blood cells, we are at risk of peritonitis. But your bigger ones are bleeding. But you are at risk of infection as well. And also the colon is thinned out a little bit, so it is at risk for rupture as well. So if you do get any constipation or stool stuck in there, this intestinal wall is already thinned out. It could rupture. So we are, as always, with any bowel disease or any infection in our bowel or any concern, anytime our bowel has any kind of hole in it, we are worried about peritonitis because there's bacteria, good and bad, living in our bowels. And anytime the bacteria open up to the peritoneal space, we're at risk of an infection in there. So this thinned colon is at risk for rupture as well, in addition to bleeding. And here's a couple more pictures of the differences between Crohn's and ulcerative. Ulcerative's thinned out. Crohn's is scarred and fat. Not fat. I see fat wrapping around the top. They're scarred and what's the word I'm looking for? Constricted, I guess. Scarred and constricted in the area. Ulcerative is thinned out and bleeding. So, what do we do for them? They both kind of have the same treatment. What causes the fat wrapping? I knew someone was going to ask me that. Don't know. Probably something to do with the immune response. I honestly have no idea. I was like fat wrapping. Oh God, no one's gonna. I don't know how to explain it. I don't know. I wish I could. I wish I could explain everything. I don't have an answer for that one. Anyway, what we're going to do to treat it is to hopefully find the triggers. If it's celiac disease, gluten's something easy to test very quickly to see if you are triggered by gluten. Gluten triggers, if it is a trigger, we will stop it. If it's just celiac disease, then that will stop the whole inflammation of the intestine. Gluten could be a trigger for Crohn's disease as well, but unfortunately there are other triggers for Crohn's, and so stopping gluten may help Crohn's, but it may not completely fix the problem. But with celiac disease, that is the only trigger. So we try to find the triggers if we can, but in the meantime, you will be giving them anti-inflammatories. Again, not our steroids. Steroids are only for short periods of time. So they have come up with this anti-inflammatory that works specifically in the GI tract. They're called aminosalicylates. And the two most common are melasmine, which I can't say, and sulfasalazine. Those two are aminosalicylates. They are anti-inflammatories for the GI tract. So they will work with any inflammatory bowel disease. And they decrease inflammation along there. So, of course, that will prevent hopefully the scarring of the tissues and keep everything under control. So those are daily doses, mesalamine or sulfasalazine, and those are the anti-inflammatories to treat Crohn's or ulcerative colitis. Hopefully we treat celiac disease, which is stopping gluten. But if you need a decreased inflammation, it will be an aminosalicytate, and it'll be mesalamine and sulfasalazine. And don't pronounce them the way I do. I'm sure I'm doing it wrong. Steroids can be used in a severe flare-up. So let's say you have a bowel obstruction due to a full, entirely obstructed bowel wall due to swelling, then they may throw some steroids on top of them for a short period. But if we give them too much steroids for too long, they could end up with Cushing's syndrome. So we want to avoid steroids if we can. They'll use them for flare-ups just to keep the bowels moving along. If those aminosalicylates don't work anymore, they may go on to whole body anti-rejection medications that suppress your whole body immune system response. And you can imagine if you are on high-dose long-term steroids or anti-rejection medications, you will end up with a high risk of other infections as well. So they want to save that unless you can't be treated with your aminosalicitates. So the treatment for Crohn's and ulcerative colitis are going to be those two meds, the aminosalicitates, so you may want to read up on those two meds, mesalamine and sulfasalazine. The other thing we can do is if this area is causing a lot of problems, if it's ruptured, or if it is constantly scarred and constantly causing obstructions or fistulas or fissures or rupture, if we're having complications, they will actually remove the inflamed part of the bowel. Oh, well, thank you. Adipose tissue is an organ with immune functions. Well, that's bad news for me. That's probably why I've got so much immune problems. Yeah, that's it, because of my adipose tissue. That's very interesting. I'm going to pop that over into the shared notes for later for me. Here, let me see if I can pop that over. I want to read that later. So I'm popping it into the shared notes. And anyone can put shared notes up here as well. I'm throwing that there into the shared notes. So now there's a shared note that we can all look at that later and we don't lose it in the chat. Anyway, it turns out, so if we're having complications, like I said, fistulas, fissures, obstructions, they will remove the piece of the colon or small intestine that is causing the problem. So bowel obstruction is an option. And look at the percentage of people with Crohn's disease that end up with intestine removal. 60 to 70%. So this is even with your anti-inflammatories. When the anti-inflammatories stop working and you end up with a lot of bleeding, fissures, infections, bowel obstructions, the doctor will come at you and say, there's two things we can do here. Your anti-inflammatories aren't working. We can put you on anti-rejection meds, which are going to increase your risk of getting any kind of infection, or we can remove the piece of the bowel that is the problem. And 60 to 70% of people, this is a better choice than being on an anti-rejection med or an a whole body rejection med, because you could die of a pneumonia or a simple infection when you can go in and remove the inflamed piece of bowel. When they remove the inflamed piece of bowel, if it is long enough to reconnect, they can reanastomosis it, and if it cannot be put back together, then it will end in an ostomy. So a lot of Crohn's, ulcerative colitis patients may end up with ostomies. And if it's a short piece of intestine that's involved, then they might be able to join it back together and anastomosis it and not have any ostomies. There is also the option for a temporary ostomy. What they do is they lop out a piece of bad intestine, let the ends heal, let things heal up, and then reanastomose them later on if they can. But again, sometimes you remove so much that you can't stretch them together, or there's so much damage, and at that point they leave the ostomy permanently. So what you can tell people after they have bowel surgery is, it's going to be dependent on how much bowel they have removed, onto whether you need an ostomy permanently or not. I've seen plenty of people come in, have bowel removed, they have an ostomy, but then as their healing and swelling process goes down, they go in 2 or 3 months later and try to reattach things so they can get rid of the ostomy. So it's not necessarily permanent, but if it's too large of a piece of intestine, they may just go to an ostomy. Does that make sense? But inflammatory bowel disease, if it's causing problems, too much bleeding, too many infections, too many obstructions, they will cut the bowel out and leave and do bowel resection. So here are our basically try to avoid the triggers. Soft bland fluids, they'll take all kinds of, if there's dietary triggers, they will try to remove those dietary triggers. So definitely we'll try to get rid of gluten, limit dairy products. Those are very common triggers for bowel issues. of course, always, whenever we have a GI issue where they're at risk for constipation, fiber and fluids, fiber and fluids. Smaller meals, let the meals kind of go through, get digested easier, and take the anti-inflammatory medications as prescribed. And there's a couple of little things about the meds, sulflazine and mesalamine. I don't know, I can't say them. But your aminosalicylates, if you see any of those 3 words, they're going with inflammatory bowel disease. Stomach upset, they can take them with antacids. They might get headaches with them. They have interactions with digoxin if you have a patient on digoxin. And with any liver impairment, we're adjusting our meds. But I'll let you look up the meds for yourself. And that finishes our inflammatory bowel disease. Those are autoimmune. They need immunosuppressants. We have, luckily, GI immunosuppressants called aminosalicylates. Irritable bowel syndrome. So notice it was inflammatory bowel disease. That is an actual disease, autoimmune, treated with autoimmune meds. Irritable bowel syndrome is not a disease. It does not change your bowel wall. It is not autoimmune. And it is a disorder of bowel muscle contraction. So sometimes you have cramps, you have too fast of contraction, and sometimes you have too slow of contractions, leading to constipation. But there is no changes in the bowel tissue. There's no increased risk of cancer. It's not autoimmune. This is basically what they're thinking is either the bowel is responding to a trigger, but what it responds to is bad function, like bad motility. So you have constipation and diarrhea alternating. You can have diarrhea with it. Is it bloody in irritable bowel syndrome? It is not bloody. There's no changing of the bowel wall going on. There's no autoimmune response. So it is not bloody. It is just straight on diarrhea, mucus-like stools if you are having hypermotility. If you're having hypomotility, then you can have constipation. So you can listen to bowel sounds with irritable bowel syndrome, but you will not see the bloody diarrhea. You will not see the low-grade fever, but you can still have diarrhea and constipation. Crampy abdominal pain you can still have when you are not moving well. So when you are having contractions, you have cramps and diarrhea. When you are having weak intestinal contractions, you're having bloating, gas buildup, and constipation. When they do a colonoscopy on it, no findings, none at all. The bowel looks pink and clean and lovely. No diverticuli, no cobblestones, no bleeding ulcers. Everything looks pink and beautiful, but the muscle layer is just doing a little bit too good or bad of a job. So unfortunately, we don't really have a treatment for irritable bowel syndrome because we're not really sure, and the treatment is aimed in either symptom treatment, taking laxatives and fiber for constipation, antidiarrheals, and antispasmodics, anticholinergics for pain. And they ask you to try to avoid as many triggers as possible. So here's the FODMAP diet. This is fermentable foods or high gas foods. So we were kind of talking about those a little earlier with Michelle. So if you have irritable bowel syndrome, they ask you, and of course anyone with celiac, Crohn's, or ulcerative colitis, they're probably asked to reduce these foods as well. They're foods that could ferment, cause triggers, cause a lot of gas buildup, and that's something we don't want to have in a diseased intestine at all. So grains, dairies, carbonated beverages, some of the cabbages, broccoli, cauliflower, I can't remember the class of category those vegetables are. Cruciferous, thank you. I was going to say, I knew it started with a C. Those vegetables that cause a lot of gas, we'll try to reduce those with irritable bowel syndrome. So the difference between irritable bowel and inflammatory bowel, not autoimmune, muscle contractions is what's involved with irritable bowel, and the treatment is really to reduce triggers, reduce high gas foods, and fiber and fluids. Need a little break? Want a little lunch? Or should we keep going through appendicitis? Ideas from the group? Okay, I got 2 goes, so I'm going. All right, appendicitis is just, that is sitting at the end, or at the beginning, I guess I should say, the end of the small bowel, beginning of the big bowel. So this right here is the, I'm going to just draw a circle around this area here. This is small intestine here, and this is the beginning of the large intestine. So this is where the small intestine meets the large intestine. At the very bottom, so it's at the beginning of the large intestine. That is where our appendix sits. And so you can kind of see the small intestine will dump into that area, and then this is where the colon starts taking it up, over, and down to go out. So the appendix is a little vestige, little old organ. Does Crohn's have appendicitis issues too? Then that's a great question. Yes, Crohn's can cause issues if it is a part of that. If the Crohn's is, come on, get small, make small, escape. If the Crohn's is in that area of the small intestine, the large intestine, yes, you can have appendicitis issues. And there we go. I just had to get it small again so we could see it. So yes, it can be found in Crohn's. It could be found just in general. The appendix becomes inflamed and infected, and it's usually due to some kind of obstruction. People don't really know what the appendix was for. There's lots of theories on what the appendix was for. It's an organ we don't use anymore. It doesn't have a function that we know of. They think that in olden times it was a place to store rocks and stones and things and stuff. In case nobody really knows. You could certainly research it, what the appendix was for. Nobody really knows, and we don't use it anymore. It is a kind of a useless little appendage at this point. The only time we worry about it is when it gets inflamed or infected. When it gets inflamed and infected, of course, now we have a little piece. Oh, well, there we go. Lauren did a lot of research, so let's copy paste. So Lauren, can you put that in shared notes as well? Do you mind? Just because I like to look at those things later. And we all might want to look at them later. And then if nobody wants them, then they're there. But that's awesome to have that stuff in shared notes, because I do want to read that. So it does have a function. Okay, good to know. Or I'll read it up on it later. But right now we can live without it. So once it becomes inflamed and infected, they will remove this little appendage from your colon. The signs and symptoms of it are abdominal cramps radiating to the groin or the back, sharp pain in the lower right abdomen, and this is where we would look for right lower quadrant pain. And this is where they talk about rigidity and guarding, but only in the right lower quadrant. Rigidity guarding means if we go to press on it, people are going to scream at you and try to move you away. And that is McBurney's point. It's kind of where the femoral artery would be in the right lower quadrant down by the groin there. And you can see the little picture there of McBurney's point. If you press on that area, you will get a reaction from your patient. Fever, chills, increased white blood cell count. It is an infection of this little organ. And by the time it is inflamed and infected, the big risk of it is rupturing and then having some bowel involved in that, which I will share an embarrassing story. I ended up having a ruptured appendix because I am a nurse, and nurses do the worst job of taking care of themselves. I had eaten at I'd worked overnight, and we had ordered food from some place that is a hole in the wall, literally. We knew it was disgusting, but we ordered food from there because it was really good, but we all knew we were going to get food poisoning at some point from this place. So we had ordered food the night before. I had eaten it, and so the next day I started having cramping abdominal pain, and I thought, oh, I got food poisoning from this hole in the wall downtown place, and great, now I have food poisoning. Nausea, vomiting, fever, yes, it hurt. it was radiating. In fact, I remember carrying a laundry basket up the stairs and thinking, I'm going to have to stop and breathe. This is like labor pain. It was very painful. So me being a dumb nurse said, oh, I think I have food poisoning. I wish I could just throw up and get this food poisoning just over with. I have food poisoning. So I assumed food poisoning, misdiagnosed myself until later on that night. And I'm starting to think, oh, now it's radiating. It's radiating. It's really bad, but it's pretty much in my right lower quadrant. I'm like, I know what this is. It hurts. It hurts. I need to get my appendix out. I've got appendicitis. Well, my husband was out. He is an organ recovery coordinator at the time and was out on a case. And I had 2 babies at home. And so I told myself, you can't have appendicitis. You can't have appendicitis till the morning because your husband's not home and you don't have anyone to take care of the kids. So probably about 3 in the morning, it was hurting so bad I couldn't. And so I called a neighbor, had her come over, take care of the kids, took myself in, called my husband, said, oh, by the way, I think I'm going to have appendix surgery. I'm sitting in the hospital now. And when they go to do the ultrasound to look at the appendix, the pain was gone. And I was like, sorry to have bothered you. I'm sorry. It must not have been. It was probably food poisoning after all. And the ultrasound tech just said, And the reason the pain was gone was because it had ruptured. So I got immediate surgery and ended up losing 6 inches of my bowel. But luckily it was anastomosed. But because it had ruptured in that area, they had to do an open instead of a laparoscopic. They had to do a washout and a reanastomosis of the bowel. So do not tell your body that you don't have time for appendicitis. So instead of being a laparoscopic overnight easy fix, it was more of a 2 to 3 week surgery repair with a couple of days of IV antibiotics. And I was too embarrassed to tell anyone that I was a nurse. Because who in the heck ignores appendicitis for 18 hours? So will you always lose bowel with appendicitis? No, not unless it ruptures and spreads infection all over your bowel. So don't be dumb. Don't be dumb. Don't tell your body this can wait when your body's sending you signals that it can't wait. But yes, no, it is very, so a little story to go with appendicitis. And you can get perforation peritonitis, but it is not a death sentence. Again, high fever, not improving with antibiotics, firm, rigid abdomen. Didn't quite get to that because, once they realized the appendix had ruptured, I was in surgery within a half an hour. So we didn't quite get to peritonitis. No, it's not supermom syndrome. It's terrible. It's the worst. And then you have to go in and explain to people, oh, I'm an ICU nurse. And they look at you like you are the biggest dunce on the planet. And you're like, yeah, I know exactly what was going on. I was just putting it off. But you can't put it off, it turns out. So appendicitis, really, what we're going to do is go in, do surgery, but always be on the lookout for the worsening cues. So if all of a sudden the pain disappears and now it's replaced with fever and growing, not just right lower quadrant pain, but now pain in the left lower quadrant and pain starting to move throughout, that could be the sign of peritonitis or a burst appendix, and that will need immediate surgery. So always keep an eye on your patient if they're waiting for surgery or surgeon to come in. A lot of patients will come in with appendicitis and they say, yeah, you need surgery, but we're going to wait and fit you into a slot. They may be waiting for a couple of hours before they need to have their surgery. And so always keep a check on that pain location if it starts to grow or it starts to reduce, but now it's having more quadrant pain rather than being localized. The temperature goes up. You may have a ruptured appendix, and that would need surgery sooner rather than later because as soon as your appendix ruptures, it is now causing a peritonitis. So that would be you need to go to surgery quicker, which, hey, I got in line quicker. So, anyway, that's appendicitis. And now we're going to talk about bowel obstruction. Need a little break, or are we good? No ideas? Well, I'm going to keep going then, because I want to try and get through this so that we can go to lunch. And you can have like a longer lunch. And you can have the afternoon. So, bowel obstructions. With appendix rupture, how long till the pain comes back? It'd probably be pretty quick. Because once the appendix has ruptured, yes, it relieves the pain from the pressure of the appendix, but as that infection spreads, it'll probably be like another hour tops before the pain comes back and you have a peritonitis. Well, I'm glad I'm keeping you amused with my dumb stories. That's the only dumb story I have. Luckily, I don't have Crohn's disease or anything, or I probably have some dumb stories from Crohn's disease too. But anyway, let's talk about bowel obstruction. Bowel obstruction can happen from any number of reasons. I'm giving you the cues for bowel obstruction, but any bowel, there are multiple reasons for bowel obstruction that we have in a minute. So let's look at the cues of an obstruction, whether it's from Crohn's, whether it's from constipation, whether it's from bowel twisting on itself. These are the cues. The higher the obstruction, the quicker the symptoms. So a small bowel obstruction will have symptoms much quicker than a large bowel obstruction. But what you will see is bloating and abdominal swelling, because what is happening here is the stomach's still making, digesting food that's creating gases. You've got a lot of air in your intestines that now has no outlet. So bloating and abdominal swelling, abdominal cramps and pain, you're trying to move the obstruction out of the way. The highlight is bowel sounds. You can pinpoint a bowel obstruction by your bowel sounds. It is hyperactive above the obstruction and normal or hypoactive below the obstruction. So this is why we listen to all four quadrants with any GI issue, no matter what it is. Listen in all four quadrants, because if you are having an obstruction, you may hear hyperactive in one quadrant and hypoactive in other quadrants, and that could be the sign of your obstruction right there. Do you have any poop with an obstruction? You can. What is getting around that obstruction? So I love this picture. This is a great picture of what is happening in obstruction. There is abdominal cramping, or that intestine's trying to push that obstruction through. So there are areas of spasm around that obstruction, and you can have fluids get by. You can have mucus get by. Your body's creating more mucus trying to push that obstruction through. So on the south end of this obstruction is air, fluids, and mucus, which can come out as diarrhea. It can come out as not even just mucodiarrhea, but regular diarrhea. Some things can get around that obstruction. You can have diarrhea and still have a constipation obstruction. You can have diarrhea and still have a bowel obstruction. So just because they're having a bowel movement does not rule out a bowel obstruction. If it is a diarrhea movement, you can still have a bowel obstruction north of that. So I've seen plenty of people are like, he can't have a bowel obstruction, he's having stools. Well, are they loose and mucousy? That's probably just the south end of the obstruction. So you can have an obstruction with diarrhea. So don't let that go. You can have constipation and diarrhea together. You can have constipation causing an obstruction and then diarrhea south of it. But your bowel sounds will be, hyperactive above and normal or hypoactive below it. Look at all the stuff that happens. Let me blow this up a little bit. I love the screen. I'm not going to rewrite everything. Look at all the stuff that happens north of the obstruction. Gas and fluid distension causing swelling of the bowel. Fluid and electrolyte loss. I'm going to circle that. Fluid and, oh, I didn't mean to cross it out. I wanted to circle it. Fluid and electrolyte loss. Whenever you have, remember our fluid, our friend here, just clear that. I want to circle it. There we go. Whenever you have high pressure, fluid and electrolytes easily get through the bowel wall, right? They were supposed to be absorbed and sent out into the bloodstream. Fluid and electrolytes pass through that bowel wall very easily. So as soon as it's descended, what is going to escape this high pressure system? Fluids and electrolytes. And so a lot of times with small bowel obstruction, you do have a lot of fluid in your abdominal space. You get a lot of third spacing of abdominal fluid. It can get into the bloodstream, it can get into the abdominal space, but fluid and electrolytes like to leave the bowel under a high pressure situation, which does push it into your peritoneal space, which means we're not absorbing it because it's been pushed out into your peritoneal space. Look at this other thing, this increased bacteria. Where are they going to go in an increased pressure environment? They go out too. They will follow the fluid and electrolytes out, which means after a bowel obstruction, what are you at risk for? Exactly, bacteria in your peritoneum. You are at risk of losing not only fluids and electrolytes, but bacteria into your perineum. So bowel obstructions can easily turn into peritonitis. So I just like looking at that picture. Digestive secretions are building up and swirling around in there, causing breakdown of your mucosal barrier and causing a possible chance of rupture. So this thing can swell so much and get so much stuff backed up and trying to escape that it actually ruptures as well. So bowel obstructions can rupture. In order to get rid of some of this pressure, not only do we have fluids and electrolytes escaping, but we have it backing up further back into your bowel. So if this is a large piece of intestine, it will back up into your small intestine. You can have vomiting, you can have gas buildup, you can have belching, you can have, but most of the time you are going to see, let me escape out of here, you're going to see abdominal distension, swelling, come on, make it smaller again, there we go, abdominal distension, swelling, cramps, pain, the bowel sounds. Worsening cues then will be fluid and, yeah, you can get it from scar tissue. There's multiple ways. We have all the ways in just a minute. But fluid and electrolyte abnormalities, because the pressure in the intestine causes leaking of fluid, electrolytes, and bacteria, you have an increased risk of peritonitis. So those mean you have worsening cues from your small bowel obstruction. So you're not only stuck with bloating, abdominal swelling, but we've got cramps, pain, bowel sound changes, and now if you end up with fluid and electrolyte imbalances, we're into a worsening bowel obstruction. So let's look at all the causes. Again, you don't need to memorize all the causes, but mechanical obstruction means that something is blocking your intestine. Something is blocking the normal movement of the intestine. You can have a hernia. Inflammatory disease causes the scar tissue, which blocks. Adhesions, which is scar tissue from an appendectomy. You can have adhesion scar tissue, which causes the narrowing of the intestine, basically causing a stricture around it, causing a narrowing. And whenever you have a narrowing, you have a risk of an obstruction. Colon cancer, constipation, gallstones, things that are blocking any normal flow through the intestine. So you can kind of look at all the different words in case you see them. Introception is where it actually slips into itself, and you can see leaves a little pocket. So if we blow up here, so adhesions can actually form all the way around and constrict this intestine. So adhesions are sitting there as scar tissue, and that's not so much the problem. But if this scar tissue starts forming around the whole thing, it can compress it and cause a constriction there. This introception, this is where the muscle wall is weak and it actually slips into itself, but then you get an infection in this area and a narrowing. So you get an obstruction and then back up into here and it starts to swell and become infected. It is a prolapse, actually. It's a prolapse piece of intestine. And then a volvus is a twisted piece of intestine, but the danger with the volvus here is, scoot, I want to make it bigger. The volvus here is it cuts off its own blood supply. In addition to having whatever's in it kind of sit there and fester, it starts swelling. So you've probably seen this happens a lot in our pets. this happens a lot in dogs. Dogs are pretty prone, certain breeds are prone to intestinal disorders, and horses. So, I mean, this can happen in any creature with a bowel. Any area of weak bowel wall. How does someone get a volvus? It's usually due to probably either genetic or something breaking down, that your bowel wall is weak and ends up getting twisted somehow in there. I don't really know exactly how people get twisted bowels. That's a good question. We could put that in the shared notes. Not really sure what predisposes you to an introception or a volvus. I think it is just a weakening in the wall that allows it to collapse. Normally it's a muscle. If you have a weakening of that muscle that holds the thing open and intact and moving, if we have a weakness in that wall, those would be what I would think, but I don't know what causes the weakness in the wall. But anyway, those are mechanical obstructions that intestinal contents can't move through, and you're having increased scarring and swelling. And then we can also have an obstruction due to paralytic ileus, which is a failure of the entire intestinal wall to move. And this is found with absent bowel sounds. So this is a little different to the obstruction. The mechanical obstructions will have hyperactive bowel sounds above the obstruction and hypoactive or normal below the obstruction, wherever that is. Paralytic ileus is the exception that proves the rule. This will cause an obstruction because nothing is moving. And this one has absent bowel sounds. So when you say your patient has absent bowel sounds, you're telling whoever is reading your charting that your patient has an ileus, a paralytic ileus. So you do not want to chart absent bowel sounds like you don't want to chart absent pulses. You have to be really sure, really sure before you chart absent, because you are telling whoever's reading your charting that your patient has a paralytic ileus. And if you chart absent bowel sounds and you do not have an intervention, that looks like you didn't do something. So what I challenge you to do is, when you are tempted to write absent bowel sounds, listen to the full 2 minutes of each quadrant before saying absent bowel sounds, because you are telling the world, when you write absent, that your patient has a paralytic ileus. And did you do anything about it? Absent bowel sounds is a pretty big charting thing, just like absent pulse. Is your pulse absent, or is it just Dopplerable? You couldn't feel it. There's a big difference. Do you have absent bowel sounds, or do you have very low motility bowel sounds? So you have super hyperactive. So when you're listening to bowel sounds, you listen until you hear them, okay? If you hear one as soon as you put your stethoscope on a quadrant, you don't have to listen forever. You hear blurp, okay, you have a bowel sound. It's not absent. You want to listen. You should have like a little blurp every 5 seconds or so. Blurp. About a normal bowel sound. I don't know what you were learned in fundamentals about your bowel sounds, but you should hear a blurp about every 5 seconds or so. You may take a full 2 minutes to hear a blurp, but if you hear a blurp, you do not have absent bowel sounds. You have hypoactive bowel sounds. If you're hearing blorp, 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 blorp every second, then you have hyperactive bowel sounds. So you're kind of listening in each quadrant, and you hear one, and then you listen again to see how far apart they are. And that will tell you whether they are hyperactive, normal, or hypoactive, or absent. To diagnose absent bowel sounds, you need to listen for a full 2 minutes in that quadrant. And you hear no blurps, then it is absent, and you may chart it as absent. If it is absent in all 4 quadrants, you have a complete paralytic ileus. If it is absent in one quadrant, you have that area that has some problems moving. So I do want you to be very careful with your bowel assessment. I know we listen, we hear a blurp, and we move on, and that's usually good enough, but really we should listen to hear 2 blurps and see how far apart they are. If they're frequent, they're hyperactive. If they are about every 5 seconds or so, then that is normal. And if they are starting to slow down and you're hearing them, but if you hear them within 2 minutes, it's still hypoactive. Does that make sense to people about bowel sounds? I want to make sure you know what you're doing when you're listening. Don't just, oh, bowel sounds active. Really take a listen. Are they hyperactive or are they absent? And please, I want you to just pause a moment before you chart absent and really listen for 2 minutes, because absent means the ileus is that piece of intestine is paralyzed and not moving at all, and that is intervenable. It's usually after abdominal surgery because we've manipulated around and kind of stunned it. So anytime we pick up our intestines and move them, so maybe you're trying to get to something behind it, like kidney surgery or something like that. Anytime we pick up and move around the intestines, we have a risk of paralyzing that intestine for a little while. Heavy narcotics decrease our stimulus. Sepsis, infections, peritonitis, any infections will kind of paralyze that bowel. But you want to listen for that. We will definitely have decrease in fluid, electrolyte, and nutrient absorption, and we will have increase in fluid, electrolyte, and nutrients leaking into the peritoneal space with the paralytic ileus. Sad story for paralytic ileus. We had a patient that I got called out on a CRT to the floor. The man was massively abdominally distended, massive, to the point where he couldn't take a deep breath. His abdomen was huge. He had a nephrectomy, kidney surgery, and now he has this huge, huge abdomen to the point where he's having shortness of breath. The nurses had been calling the doc to let him know that they didn't hear bowel sounds and that he was getting distended. And the doc said, get him up and walk him, which is actually one of the treatments for a paralytic ileus. Getting him up, moving him, stimulating muscle motility stimulates gastric motility. So he said, get him up and walk him. And they've been getting up and walking him, except that he was swelling more and more and more and more. And it was now starting to affect his breathing. So they called the rapid response. We take a listen. No bowel sounds. I mean, listened hard. I'm listening for any bowel sounds. He had a few in the lower quadrant, the right lower quadrant, or the left lower quadrant, sorry, a few colon bowel sounds left, but everything else was silent. So we call the doc and say, hey, your patient, I think, has a paralytic ileus. Can we get a chest x-ray? Can we get an NG tube? Because we're going to talk about the treatments for it. Was asking for the treatments for an obstruction. And he said, those nurses need to walk the patient. And I said, I understand that, sir, but I think they have been walking the patient, but he's getting short of breath now because his abdomen is so distended and he's having a hard time walking. And he goes, would you want an NG tube? I said, really not really a fact right now, but no, I wouldn't like an NG tube, but I think if my abdomen was this full, I would probably want something to relieve the pressure. And so he finally begrudgingly gives me an order for an abdominal x-ray. So I said, that'll be fine. Get your abdominal x-ray. You'll see paralytic ileus on the x-ray, and then he probably just wants to be right. He doesn't want me to be right, and then you'll get your treatments. So that was the end of the CRT. We got the abdominal x-ray. This was the end of the night, so I didn't follow up. So I come back to work 3 days later, and I find out that this patient died the next day. Because I don't know if he never looked at the x-ray or what happened with the patient, but he ended up from this paralytic ileus becoming septic and dying of this paralytic ileus. So again, it's a sad story, a very over dramatic story, but unfortunately it did happen. The patient had a nephrectomy, had abdominal surgery, high risk for paralytic ileus, was getting narcotics post-abdominal surgery, again, a high risk for paralytic ileus. He developed a paralytic ileus, but it was not caught. And when you do not catch the obstruction or fix the obstruction with the proper treatments, you can die of these fluid electrolyte bacteria abnormalities. So let's fix all of our obstructions so this never happens. And again, it was not the nurse's fault. It ended up pinned on the physician for not treating his patient. But fix the problem is we will make the patient NPO. If you have a bowel obstruction, let's not add anything else to the problem. NPO. They're probably not going to feel like eating anyway because they have an obstruction, but NPO to fix it. NG tube, and what is the NG tube going to do for you? Why would you put an NG tube into a bowel obstruction? To decompress, to get rid of that air. We want to get that air out of the swelling bowel. So we are going to decompress from the top end and pull air out of the bowel. So the NG tube will decompress the bowel to prevent rupture and fluid and electrolyte and bacteria from crossing the wall. So decompression is very important to get that, so we avoid the worsening symptoms, which are peritonitis and rupture. Antibiotics. If you're always worried, you're worried about bacteria crossing that wall with an obstruction, so they will get antibiotics to prevent that bacteria from causing a peritonitis. Most bowel obstructions, and this is mechanical bowel obstructions, okay? So all of these, hernias, inflammatory disease, adhesions, colon cancers, severe constipation, most of them will go to surgery. The one thing that will not send you to surgery is having a massive bowel obstruction. We will need to do something from constipation. We will need to do something for constipation. And I think I have that under, that one's not there. All right. Well, I got to fix this slide too. Lord have mercy. I thought I had an extra slide for constipation, because it's the thing that proves the rule. They're not going to go in and surgically remove your blockage. You're going to get, so we're going to say surgery, or, what am I going to call this? We're just going to call this bowel care. So the thing is that if it is not they'll do your, let me redo this. Let me fix this slide. Any bowel obstruction will be NPO, NG tube, and antibiotics if it is causing that much distension. Let's see where I want to put this. I want to refix this all. Let me think about this. Let's do, in order of what we would do, is one, you're going to make the patient NPO. You found it. We're going to make them NPO. You need to kind of get a diagnosis on it to figure out, is it constipation or is it a volvulus? So they'll probably do diagnosis second. Because they need to figure out what it is. And then I think we're going to go into a flow chart. If constipation, you're going to get enemas, laxatives, IV fluids. You're going to basically try to get rid of that. You're going to get creative with your bowel care to remove this. You're going to make sure they're hydrated, make sure that they are getting everything needed to remove that obstruction, that impaction wherever it is. If it is, I don't want to say bowel wall. If other, we're just going to say if other. Because constipation, we're not going to go straight to all these big things. We know what the problem is. They will go in there and fix it. If other, mechanical. Then we will move on to trying to think. IV fluids. Sorry, I'm thinking. NG tube does decompression. IV fluids for fluid shift. Oops. Shifting from bowel. Antibiotics to treat the bacteria. I'll have to post this lecture back. And electrolytes. All right, does that make a little more sense? So they will be getting IV fluids, NG tube, and then they'll... Okay. Let's try that. All right, so there's your revised slide for treatment of mechanical bowel obstruction or blockage of flow through the intestine. All patients should be NPO and get a diagnostics because we need to figure out what is causing the obstruction. If it's constipation, we will give IV fluids, enemas, laxatives, get rid of that constipation piece. If it's another mechanical obstruction besides, then they will do an NG tube to decompress, IV fluids, antibiotics, electrolytes, and surgery. Does that make sense for you guys? Everybody likes the order? Any questions, concerns? Okay, so that one's going to be, I'll update this slide. I'll put this new PowerPoint up at the end. So that's mechanical treatment. If you have a paralytic ileus, again, I told you if you document it, then we would need to, so this would probably be, again, let me fix this one. So again, it is so NPO, and then diagnosis. So I should have probably labeled these a little better. So you're getting, every semester, it gets better and better and better. We will try to fix the paralytic ileus first before going into all the rest of this. So let's see. Okay, I think that fixes this one. So no food in there. It's paralyzed, so we shouldn't be eating food. So NPO, get your diagnosis. So the same as if it was mechanical, but then they will see that the entire intestine is distended. They'll do the diagnosis of paralytic ileus, and then what they will do to try and fix that are gut motility stimulators. You may see these actually after or with patients that have a high risk of paralytic ileus, that they'll do these proactively. Reglan, you've probably given Reglan to a ton of people. You might have given this Relistor or the methylnaltrexone. If you have a patient that's on high-dose narcotics that can cause a paralytic ileus, they'll give them the Relistor. This one will actually block the action of the narcotic on the GI system, so prevents that narcotic from slowing down the GI system. So patients on high-dose narcotics that they can't wean off, they may do Relistor to try and prevent paralytic ileus. They may be in a surgery that had a lot of GI manipulation. They may do Reglan right afterwards just to prevent paralytic ileus. So I'm going to write on there that we can give these preventatively. Prevent or treat ileus. So those gut motility stimulators are important if the surgeon knows that there's going to be a lot of GI issues they may put your patient on Reglan. So gut motility stimulators will try and get that gut moving again, decrease narcotic use if we can, and if those interventions are not successful, then they will get an NG tube for decompression, antibiotics, IV fluid, and possibly TPN if they're going to be NPO for a while. Make sense? As soon as that gut comes back, though, we want to use it. Peritonitis, I'm not going to spend a lot of time on. We've talked about it in multiple sessions, but worsening symptom of any GI disorder, inflammation, infection of the peritoneal membrane. That's supposed to be membrane. This tummy's too big. And those are your signs and symptoms. So if you haven't learned peritonitis signs and symptoms, this is where you have to learn them. So there they are. And for peritonitis, to fix the problem, antibiotics, fluid and electrolyte replacement, NG tube, NPO, and exploratory laparotomy if there is damaged intestine in there. Any questions on that? And I'm going to take a little break. I need to run on a bio break.